This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm your host, Amanda Dee. Recently, the director of the CDC officially recommended that pregnant women receive the vaccines for COVID-19. However, pregnant women are less likely than non-pregnant women to get vaccinated and are at greater risk of hospitalization and death from the disease. Dr. Emily Miller has been caring for pregnant patients at Prentice Women's Hospital since the onset of the pandemic. She shares results from a new study on the benefit of maternal vaccination and speaks to the history of excluding pregnant women from clinical trials. Dr. Miller is an assistant professor of obstetrics and gynecology and of psychiatry and behavioral sciences at Feinberg. Thank you for joining us today to discuss this timely and important topic.
Thank you so much for having me.
A year ago, when we had more questions than answers about SARS-CoV-2, you published a study showing injury in placentas from women with the virus. How did that finding influence your treatment of pregnant patients with COVID-19?
Yeah, it's a great question. And I think thinking back a year ago, what a difference this year has made in our understanding. At that point, we really had no idea what the clinical implications were of this virus in pregnancy and what to expect in terms of maternal outcomes and neonatal outcomes. And so I partnered up with a phenomenal group of researchers. And while you're hearing my voice, I really just want to amplify the voices of those who contributed to this work because it has certainly been a team sport. And I've been really lucky to collaborate across multiple departments within Feinberg, which has been really fulfilling and rewarding. But our thought process was that placental findings perhaps could indicate potential clinical risk that and maybe could be an early signal for rare injury that would only be seen after widespread infection in the pregnant population. And so maybe by looking at placentas, we could see harbingers of future risk, and that would inform the clinical surveillance we should do until we had the epidemiologic data of what that actual risk portended. And so we did find and have consistently found a subset of lesions in the placenta that point to increased risks of things like preterm birth or growth restriction. And so these findings, alongside those of many others across the country, have informed the recommendation for ultrasounds to measure fetal growth after SARS-CoV-2 infection during pregnancy.
What are some of the common adverse outcomes in pregnant women with the disease? What about for their babies?
So what we've learned is that pregnancy and childbirth do not generally increase the risk for acquiring the SARS-CoV-2 infection. And pregnant people tend to have similar symptoms if they do develop symptoms, but they're slightly less likely to have symptoms compared to non-pregnant people. However, we also know that if they do become infected, they're more likely to develop severe manifestations of disease. So, for example, pregnant people compared to similarly aged women have a 5-fold increased risk of hospitalization, a 3-fold increased risk of ICU admission, and nearly a 2-fold increased risk of dying from COVID-19. In terms of their babies, one of the original foci of research was focusing on perinatal transmission, with the concern that the virus could cross the placenta and newborns could be born infected with this virus and potentially with some pulmonary manifestations of that infection. Fortunately, we've seen that that is the exception rather than the rule. And while there have been some cases of perinatal transmission of SARS-CoV-2, it seems to be less than 2% of pregnant individuals.
And despite this increased risk, pregnant and lactating women were initially excluded from clinical trials for vaccines in the U.S., though this is standard protocol. Tell me more about the history and debate of pregnant women in clinical trials.
This has been an area of advocacy for myself and many organizations that I'm fortunate enough to work with for decades. Historically, the concern has been that we don't want pregnant people to be first in line to participate in a trial because the implications, if there were any adverse events that were seen, are magnified in pregnant people compared to non-pregnant people. And we have this additional layer of uncertainty with respect to the pregnancy. The flip side, and I think this is particularly amplified during the pandemic, is time is not on our side. And the alternative to not being involved in these research studies and not having these therapeutic modalities at our fingertips, knowing that they work, that they have similar efficacy in pregnant people, right? That alternative is that pregnant people become more sick and that they die. And so, in the setting of a pandemic, that really changes and that algorithm changes is that, yeah, maybe they don't need to be the absolute first in line, but gosh, we need to start reframing um, from we need to, the historical perspective of we need to protect pregnant women from research and really convert it to we need to protect pregnant women through research.
That's a great statement. Why can this history and this protection by exclusion be harmful or confusing for women?
I think right now the language that's being used by the CDC and the American College of OBGYN and the Society of Maternal Fetal Medicine is as good as it can be, but it really stops short of overtly recommending vaccination. And the reason for that is that these organizations recognize that we do not have data on safety and efficacy at the level that it needs to be to overtly recommend the vaccine. And instead, they use language like the vaccine should not be withheld or pregnant people should have access to the vaccine. And I think those subtle language differences really matter because it promotes this vaccine hesitancy of, well, it's not overtly recommended, or it introduces the concept of this pause that would be best filled by having the data behind our recommendations.
In addition to these subtle language choices, there have also been some false reports circulating online about the vaccine and its effects on pregnant women, but also on its effects on fertility. Can you dispel some of those reports for us? Why is it also important for women who want to get pregnant in the near future to get the vaccine?
So I think recognizing the clinical implications of COVID-19, particularly in pregnancy, amplifies the importance of getting the vaccination prior to pregnancy if you're thinking about a pregnancy in the near future. It also shouldn't impact when you become pregnant because we really don't want to delay receipt of the vaccine because we're still living in this pandemic. It is so important that we get people immunized because the alternative to not receiving the vaccine when you're living in an area where the virus is circulating is that you could become infected with the virus and you could become really sick. So I think it's really, really important to frame it's not a decision about either not getting the vaccine or just magically not getting COVID, right? It's about either not getting the vaccine, which carries a risk of disease acquisition. The rumor that you talk about infertility has certainly, I think, damaged a lot of vaccine uptake, and we've seen this with other medications and other vaccinations. Is this concern? In this case, what had been circulated is that the spike protein, right, what the mRNA vaccine or the adenovirus-based vaccines are using to promote immunity, have some homology, have some similarities in their genetic sequence to a specific protein that's a part of the placenta. And so the concept is that if the immune system is primed to react against that spike protein, it could be tricked into thinking that a forming placenta carries that same antigen, and it would then attack that placenta and result in infertility or early miscarriage. The truth is that homology is not clinically meaningful. There's not such overlap that we would expect cross-reactivity. So we wouldn't expect the same immune response against SARS-CoV-2 itself to occur against the placenta. And I think when I think like a clinician, when women get SARS-CoV-2 infection during pregnancy, we don't see that they immediately go into preterm birth or that they have a stillbirth, right? That's not a common clinical sequelae because the infection, it's not attacking or promoting the immune system to attack the placenta.
In April, you published a study in the Journal of Obstetrics and Gynecology that speaks to the positives for the newborn and fetus through vaccination. It found that women who were vaccinated for COVID-19 earlier in their third trimester had a higher likelihood of passing protective antibodies to their newborns than women who received the vaccine closer to delivery. Tell me more about this finding.
This was early data from people who got vaccinated in the first few months when vaccine was distributed. And so it's important to remember that these are predominantly healthcare workers because that was in the early phases of distribution. That being said, what we did is we collected maternal blood as well as cord blood at the time of delivery from these maternal infant dyads and analyzed the amount of antibody that was produced. And we did this really to look at, does this protective antibody, does this thing that's protecting the pregnant person from serious COVID-19, does that transfer and offer the potential for protection to the newborn? And I think what's so exciting is that the efficacy, the immune response in pregnant people was really robust. People who got 2 doses of that mRNA vaccine had a really pronounced antibody response. And so that gives us some preliminary signal that these vaccines are efficacious in pregnant people. That's really exciting because at the heart of all of this, while I think our data about neonatal protection are important, right, it's maternal protection that needs to be first and foremost in our minds. And so we see that early signal of efficacy. We also saw that the transfer across the placenta to the infant was really robust, which suggests to us that these neonates have some protection against acquisition of SARS-CoV-2 in their first few months of life. And then the more exciting thing is the longer time we had from the when the vaccine was given until delivery, the more robust the transfer was. And so these data, again, very preliminary, but suggest that getting the vaccine earlier may provide enhanced benefits to the infant.
These are exciting results. And the study was, as you said, preliminary. It used a small sample size. What's next for the study?
So I think the important thing, and actually just speaking with folks at the CDC, one of the pauses that we all have, the CDC included, about changing from not withholding to recommending the vaccine in pregnant people is, what is the safety and efficacy in the first trimester and second trimester? And so part of that is just time has to pass because it's only been a handful of months since the vaccines were approved. But we are actively collecting these samples and placentas of folks who have been vaccinated so that we can quickly analyze them and be poised and ready as soon as we have sufficient data to give those early signals of safety and efficacy that are needed to change the language to overtly recommending vaccination in pregnant people.
As you said, research has been moving very rapidly during this time. How have you been integrating some of these findings into your work in the clinic?
Yeah, it has been a fire hose of information, and it's been exciting and energizing to have this rapid turnover and be learning, but it's also fairly exhausting. And so I think finding mechanisms to be able to communicate our findings to other clinicians to make sure that they are aware of, what's out there and what's the latest data has been both an opportunity and a challenge. Really learning that in medicine, our mechanisms for dissemination leave room for improvement. I also think some of, again, these pauses that we've talked about in this conversation are heard very loudly by the public, and opportunities to partner with community, to listen to the voices of those in community, to hear what their hesitancies are and to start to address it. So it's partnering with community organizations who are in the field, on the ground, working with patients in their own settings to start to dispel these myths. All of these are really important mechanisms to reduce vaccine hesitancy and to make sure that we are not introducing inequities in distribution and uptake of the vaccine.
As you're talking about with public health, risk is deeply personal and affects different communities and individuals in different ways, especially when we're talking about the health of someone's baby. Besides looking to community partners, what strategies would you offer to healthcare providers and communicators looking to address pregnant women's concerns about vaccination?
Really great question. And I don't think there's a very definitive answer. I do think strategies that have been proven effective, number one, is listening, right? Not starting with, you should get this, or rushing in, but what are your thoughts and feelings about the vaccine? What gives you pause? Or are you ready to go and let's get this vaccine now? I think integrating that information into the response really helps develop a partnership and an alliance and a sense of shared decision making, which is incredibly important, particularly because pregnant individuals have been excluded from a lot of this research. I also think the framing of these decisions is really important. And so a lot of individuals that I talk to will just say, I don't want to get the vaccine, but I also don't want to get COVID-19. And reflecting how those aren't really the two options that are in front of us, and how it is so important to reflect on that decision and think about that decision as either have ongoing risk of disease acquisition and not get the vaccine. And so, again, not have that uncertainty regarding the vaccine efficacy and safety or whatever remains therein, or get the vaccine and know that your odds of severe morbidity and mortality are dramatically reduced. And so I think presenting that framework is really helpful. And there's some really useful decision aids that have been circulated to help us with that communication.
Many comparisons have been drawn between SARS-CoV-2 and HIV. Some of your research focuses on pregnant women living with HIV. How has your work with HIV prepared you for this coronavirus outbreak?
I'm so fortunate to work with two unequivocally amazing maternal fetal medicine clinicians, Dr. Pat Garcia and Dr. Lin Yi, in our women's OB/ID program. And what that's taught me are the essentials of having multiple pillars of an approach, having research, having community outreach, having advocacy, and having education all be pieces of the puzzle. And I think integrating those structural approaches to this pandemic has been really beneficial. We've talked a lot about the research aspects, and those are really, really important. They're moving the needle forward. I think it's also important that we integrate our learners into the research and the clinical care. And I've been fortunate enough we have a surplus of phenomenal trainees, from students to residents to fellows and beyond. So I've had great opportunities to partner with them to conduct some of this research, which has been really rewarding. Advocacy also has been amplified here, just like in the HIV pandemic. So, recognizing the role that we have as clinicians to also be advocates and to be the voice for folks whose voice is often overlooked or not heard. And so, taking a lot of the things we've talked about, the importance of inclusion of pregnant individuals in clinical research, how that's impacted our clinical care, and taking that to congressional briefings or, writing recommendations to the CDC have all been really important parts of this work to make sure it doesn't just stop with a couple studies, but we're really moving the needle forward.
Thanks for listening to Breakthroughs. If you liked what you heard, head to feinberg.northwestern.edu, where you can also earn continuing medical education credit for listening.